started your timer, and here is your question. Not so much, but right. So if you have read and understood considering this surgical anatomy station, kindly tell me what is this that you're looking at right now?
This is a piece of the skull.
Okay. Would you be able to identify what are the bones that you can
Yeah,
see?
it's a frontal bone. And in the middle, it's a lesser wing of sphenoid, greater wing of sphenoid, and a temporal bone. And posterior, it's a occipital bone with the foramina magnum.
Okay. Can you please tell me this skull bone is divided into 3 fossae? Can you tell me how this division is?
It is divided into anterior fossa, middle cranial fossa, and posterior cranial fossa.
Okay.
Anterior cranial frontal bone. With posteriorly, it's bond sphenoid, and middle cranial fossa is bound by the lesser wing of sphenoid, lateral temporal part of a temporal bone, and posteriorly will be the greater wing of sphenoid.
Okay. Can you please tell me if you can identify and tell me what passes through this 46 over here?
Ma'am, 46 is the spinosum.
Yes, but what passes through it?
Ma'am, foramina spinosum, usually it passes middle meningeal artery with sometimes the meningeal branch of mandibular nerve.
Okay. Yes, middle meningeal artery. Okay. Can you please identify and tell me what this foramen 12 is?
Ma'am, foramen 12 is foramen ovale.
Okay. What passes through it?
Ma'am, there is a mnemonic for this. It's an ovale, O-V-A-L, O for aortic ganglia. V is for, it is the mandibular branch of trigeminal nerve. And E is the meningeal artery. L is the lesser petrosal nerve, and E is the emissary veins.
Okay. Can you please tell me what's the significance or what are the contents of middle cranial fossa?
Middle cranial fossa, there is
temporal lobe.
In the central, there's a pituitary gland. There's a sella turcica, pituitary gland, and on the other side, the sinus, and middle cranial, midbrain.
Okay.
On the lateral side.
Can you identify, yes, the impression of trigeminal ganglion?
Trigeminal ganglion?
Yes, please. In middle cranial fossa, would you be able to identify it?
Sorry, ma'am.
Okay, can you tell me what is pterion?
Ma'am, pterion, actually, it's a junction between the bones on the lateral part of a skull. It is the junction of frontal bone, temporal, parietal, and sphenoid bone.
Okay,
this landmark is important. Its significance is because the thin bone and middle meningeal artery. So any trauma in this area can lead to the EDH, leading because of the injury to the middle meningeal artery.
Yes. All right. Can you please tell me what is cavernous sinus?
Ma'am, cavernous sinus is a space in the middle cranial fossa, which is bounded medially by the fossa, by the lesser wing of sphenoid, and laterally by the drains, ma'am. It drains the blood supply from ophthalmic artery ophthalmic vein, facial vein, drains into the internal and inferior petrosal gland. Significance of and the contents of this.
Yes, ma'am. Continue, please. Yes, the contents of the.
And the contents of the cavernous sinus is the inside. It contains the fourth and fifth and sixth cranial nerves on the right from above to below. It is first oculomotor, then trach.
Can you please tell me how the thrombosis of cavernous sinus takes place, or how it occurs?
Actually, that drains the blood from the facial and ophthalmic veins, and if there is trauma or inflammatory process in this area, and it causes retrograde infection and retrograde this thrombosis of these
How the patient with cavernous sinus thrombosis would present?
They usually present with eye pain. They have an eye pain, congestion of eyes, and headache. They have headache, and ma'am, they can present with a fever.
Okay.
So, and it's they have.
Can you?
Because there are 3 or 4 cranial nerves, 3 can present with the palsy, and also they have a gradual loss of vision, so they can have because.
Would you be able to identify right or foramen lacerum?
Ma'am, lacerum is 10. Foramen lacerum is the mark. No, yes, ma'am. Foramen lacerum 10.
Isn't it foramen right now? Or is it 10? Yes, it's 10. All right. Okay. Can you please tell me the contents? What passes through it?
Ma'am, usually it is there is a cartilage. Cartilage is not there is no structure, so it's not passing. But lacerum, they traverse nerves, the pterygoid canal or arteries, the pterygoid canal. But usually they are occupied by the cartilage. There's a this is
what
sometimes
attaches to styloid?
Yes, ma'am.
What attaches to stylomastoid foramen, or what passes through it?
Facial nerve, styloid is a facial nerve and
stylomastoid artery. Okay. Can you identify the structure 11, please?
It's a foramen magnum.
Yes. What are the contents, or what passes?
Foramen passes, ma'am. There is a lower end of medulla. With sometimes spinal root, the spinal root of accessory nerve, with arteries. There are arteries, vertebral arteries, and anterior and posterior spinal arteries.
Yes.
And also this tectoral membrane sometimes, and ligaments, and this ligament of the den.
Yes. Yes. Good. Thank you.
Thank you.
Yeah. Good. Where is your question? Right. So if you have read and understood, considering its surgical pathology station, kindly tell me if you can describe the lesion you're looking at, please.
Okay, it's a raised,
Yes. And
papular lesion with rolled edges and some surrounding dengalectasia.
very good. Okay. Considering looking at this condition and you have already read the stem, what are the differential diagnoses that you would consider?
This one is likely going to be a basal cell carcinoma.
Very good. Yes. And
Can be a squamous cell carcinoma.
yes.
Can be a melanocytic melanoma.
Very good. Can you please tell me what, how would you confirm your diagnosis? What are the investigations that you would ask for?
Investigations are do full blood count. I will do an ESR. I'll also do a biopsy, excisional biopsy of the lesion.
Okay. Once taking the biopsy for this lesion, what are the things that you will keep in your mind or you will consider?
Okay, when taking the biopsy, I will take the biopsy with 0.5 millimeter margin. And then after the biopsy report, then likely I will have the excision to make sure all the edges have been cleared.
So it is the margins and then it is the depth of the invasion you'll consider.
Yes.
All right. Okay. Can you please tell me if it is just suppose it's basal cell carcinoma, then can you please tell me the pathogenesis behind it, how this basal cell carcinoma occurs?
Hello?
Yes. Can you tell me the pathogenesis of basal cell carcinoma?
Okay.
Or the natural history, you can tell me.
The natural. Okay, it's slow growing.
Yes.
And it's locally destructive.
Yes.
But it has limited risks of metastasizing.
And it originates from where?
It originates from the
with germ layer. Okay, how would you differentiate it from squamous cell carcinoma?
Okay, squamous cell carcinoma usually found near the body orifices, while basal cell carcinoma is found deep within the layers of the skin, and then it occupies. Usually, basal cell carcinoma, like in the picture, is red, pale, and then pearly with some rolled edges, while squamous cell carcinoma, it's red, crusty, may even have ulcerations. And then usually squamous cell carcinoma effects arise from superficial layers of the skin, while basal cell carcinoma from the deep layers of the skin.
Yes. Okay. Considering this, that you took the biopsy and the biopsy came back and it shows that it is basal, it confirms that it is the basal cell carcinoma, then what is the treatment or management options that you can offer to this patient?
Treatment options can be surgical or radiotherapy,
yes,
or maybe topical. Surgical can be excision with adequate margins and primary closure. It can also be used of cryotherapy, liquid nitrogen, and radiotherapy. Then maybe topical creams like 5-fluorouracil and other topical cytotoxic agents.
How, okay, once you are excising the lesion, how would you make sure that to prevent recurrence of the lesion?
Okay, I will do Mohs microsurgery.
Yes. You'll take deep margins. Okay. Right. Can you please tell me if you have excised this lesion and there is a gap, how would you cover the gap, or would you stitch it, or would you apply a graft, or how would you take care of the wound?
I will follow the reconstruction ladder.
Yes.
If a primary closure is not advisable, then I will go for a graft or a flap.
Okay. Just suppose you've chosen to have a graft, skin graft, and the patient comes back and there is a wound infection. What is the most common organism that you would suspect or think of?
So usually it's Staphylococcus aureus.
Okay. How would you go about manage the wound infection then?
Okay, I will take I will take a wound swab MCS.
Yes.
Then I will commence the patient on the broad spectrum antibiotic.
Yes.
Then after the culture result is out, then I will give the patient specific antibiotics for the infection.
Okay. Just suppose patient's result comes back and patient is positive with MRSA. Then
Okay.
what are the special measures that you will take?
Can you come back again?
Yes. You send the swab and the result comes back and patient is MRSA wound infection positive. What are the
Okay.
measures that you'll take now?
Okay, if the patient is MRCS positive, I will commence the patient. We'll start after a multidisciplinary approach. I will inform the nurses and to take measures against cross-infecting other patients in the ward. I'll start the patient on IV vancomycin or maybe tacopladin for 2 weeks, and then I will give the patient nasal mupirocin or chlorhexidine body wash to decolonize the body, and then I will disinfect and decontaminate the ward, and then avoid overcrowding the patient and place the patient in a single room in order not to cross-infect the remainder of the patient.
Okay. This particular patient visits you after 8 months and has a lymphadenopathy. Then what would be your approach towards the patient? What would you suspect?
Okay, I will suspect the patient has a reoccurrence and a lymphatic spread of the tumor.
Yes.
So I will start by doing an FNAC on the patient,
Yes.
which will likely reveal the histological diagnosis and the immunohistochemistry.
Yes.
Then to know the primary, the cause of, and then commence the patient, re-excise the lesion and commence the patient treatment.
Good. Very good. Good. Thank you. Started, and here is your question. Right. So if you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this patient now?
According to the scenario, maybe the patient's suffering from the anastomotic leakage.
Okay.
So I will manage the patient according to this protocol.
Yes.
And so patient should be in nothing by mouth, and let's start IV fluid, IV antibiotic, and the tube for suction, and catheterization for monitoring urine output. Then I will give broad spectrum IV antibiotics and analgesic and anti-ulcerant. And I will do the investigation, a full blood count, serum creatinine, electrolyte, and CRP. And
Can you please tell me,
Uh,
in a post-operative patient just like this one, what are the causes or what are the contributing factors that lead to or that can lead to anastomotic leak, or that can lead to this situation which patient has right now?
there are some patient factor and some surgical factor.
Very good.
Patient factor such as if the patient is suffering from any comorbid condition
Yes.
like such as diabetes mellitus or taking a steroid or any invasive drug. Patient is suffering from nutrition, and in the surgical factor, there's if the surgical feed being contaminated and there is inappropriate use of suture or stapler, and there is too much tension in the anastomosis and blood supply. There is compromisation of blood supply. This can lead to anastomotic leakage after anastomosis.
Okay, can you please tell me, considering the ABGs which is shown here for this patient, how would you correct or how would you help the patient correct its ABGs?
Even partial pressure of carbon dioxide level, this is metabolic acidosis.
Yes.
This is due to there is anastomosis leakage, so there is loss of fluid and gut content in the peritoneal cavity. So patient is suffering from the septic shock, and that's why and hypoxia. So there is metabolic acidosis. So I will give the patient the IV fluid to maintain the hemodynamic and monitor the urine output and make the patient hemodynamically stable and correction of shock. And
Yes.
so
In order to stabilize hemodynamic patient, how would you take care of the raised potassium and creatinine levels?
in case of raised, if there is raised potassium level,
Yes.
first I will I take care of the patient is due, and I will stop all potassium containing food, including Hartmann's.
Good.
Then I will give injection calcium gluconate 10% for 10 minutes to stabilize the cardiac condition, and I will start injection in a shorting insulin with 50% glucose within 30 minutes to shift the potassium inside the cell. And if there is still raised potassium, then I have to shift the patient for hemodialysis.
Very good.
And for serum creatinine, I have to monitor the urine output and correction of shock. And if there is adequate urine output, and then I will maintain the fluid. If there is less urine output, I will give the injection furosemide and to maintain the urine output. And if there is still less some creatinine, then I have to shift the patient for hemodialysis or renal output.
Right. Considering the condition that patient has persistent fever and patient is tachycardic as well, so you send the blood test, complete blood test, and the report comes back. What are the things or the factors that you look out in the blood report to confirm that patient is suffering from sepsis or SIDS?
There is a total, there may be neutrophilic leukocytosis in the
Yes.
whole blood count report and increased CRP.
Yes.
And if procalcitonin level is down, then this will be also raised in this condition. And
yes. Okay.
And maybe patient suffering from anemia also.
Yes, that is also possible. Okay, can you please tell me what is, if, okay, now that you know that patient is having infection, so what is the most commonly occurring organism which causes infection in postoperative patient?
In case of anastomosis leakage, common organism may be E. coli, Escherichia coli, and others,
Oh,
maybe
Staph.
there is others,
Okay. Yes.
Pseudomonas proteus and
Staph
bacteroides. This may be added. as
Yes. What
epidermis.
measures can you take then to manage this condition of the patient?
Scenario, patient is suffering from fever, tachycardia, and breathing. So maybe patient suffering from generalized peritonitis and hemodynamically unstable. So if the patient is having generalized peritonitis and hemodynamically unstable, so I will go for exploratory laparotomy and drainage of the content from peritoneal cavity and put a drain and there is a few option. I categorize the anastomosis as a colostomy, or I will make it an end colostomy, or maybe proximal diversion and re-anastomosis of the and re-anastomosis.
Good.
Or
Okay.
if the patient condition is too friable, then I can make only put drain and proximal diversion.
Very good. Okay. Where would you manage this patient, and who would you involve in the management of this patient now?
I will manage the patient in the HDU, and I will involve the anesthetist and colorectal surgeon and
Yes. And
card and ITU specialist.
yeah, could be, because no patient could even go in the end organs. Okay, how would you write? You have already told me. How would you take care of tachycardia for this patient, or breathing difficulty?
Tachycardia, maybe patient is suffering from tachycardia due to septic shock. So I will introduce IV fluid and IV antibiotic to correction of sepsis and shock, and
Yes.
monitor urine output. So if the patient, and maybe this is due to fever also. So if the sepsis is
Yes.
controlled and shock is corrected, this will be corrected.
Will, yes, go by itself. Good, thank you. Here is your question. Right, so if you have read and understood, considering the communication skills station, kindly begin.
Hello, I'm Dr. Ma, one of the certificate doctors here. So I've been asked that you have two questions. So but before starting this, can I confirm your name and age, please?
Tony.
Hi, Tony. Nice to meet you
Yes.
today.
Mm-hmm.
Yes, Tony. So what do you know? What do you know so far?
So I don't have any idea about this medication, but my doctor told me that I shouldn't stop it because stopping will threaten my life.
Yes, your doctor is right. You have been taking the drug called warfarin. So I will explain to you why this drug is necessary for you. Okay, so first off, you have got a mechanical heart valve replacement based on your medical records. So because of that, you have to take that drug, which has blood thinning effect to prevent the blood clots on your heart valves, which was replaced earlier. This is why you need to take that drug. And Another thing that I'm going to explain to you is that you have to undergo a surgery for your inguinal swelling. Is that right?
Yeah.
Yeah. So before starting the operation, to reduce the risks during operation and after operation, you have to stop the drug because we don't want to very major events of bleeding while during the operation.
Okay.
So are you over, Tony?
Okay, I agree with you. So, should I start this medication before the operation?
Sorry?
Should I stop this medication before the operation?
Yes, you have to stop this drug 5 days before the procedure because the drug warfarin has very long duration of action. So you have to stop it 5 days before the procedure. And meanwhile, three days before the procedure, we will give you another drug called heparin, which has the same blood thinning effect as warfarin does. However, this has a very short duration of action, so it can be stopped 12 hours before the procedure. So we can reduce the risk of bleeding. I will.
Okay, so why heparin?
Why heparin? Yes, as I said.
So why?
As I mentioned before, compared to the drug warfarin, it has the same effect, but shorter duration of action, so that we can stop the drug 12 hours before your surgery starts.
So when can I restart warfarin?
Yeah. Once we have make sure that all the bleeding points are controlled, we will restart the heparin. And once you can tolerate swallowing the pills, we will restart warfarin along with heparin. Meanwhile, we will be checking your blood INR level so that you don't have any incidents of bleeding. If once the INR level has reached to the optimal level, we're gonna remove the heparin and you can continue taking your warfarin as you usually do.
Okay, so is it necessary to stay in the hospital before the operation?
Before start, because of the hospital-acquired infections, we don't necessarily admit the patient very long days before the procedure. So you only need to admit to the hospital 1 day before before your surgery. Yep.
Okay, but you told me I should stop this medication 5 days before the operation. So should I stay during this duration in my home? Should I admit it in the hospital?
Yes, to inject this kind of drug, we have a lot of doctors and nurses to teach you how to inject yourself. And it's pretty simple and easy. But if you are really afraid to inject yourself, you can bring one of your family members, or if not possible, we can arrange a district nurse who will come to your house regularly. With that.
Yeah. But is it necessary to stop my anti-anxiety medication before the operation?
No, you don't have to. You can continue. You can continue your anxiety medications, but before your operation, you will be on the fasting. You will be on fasting so that you can only take your medication only with a very small sip of water.
Okay.
All right.
Okay,
so, Mr. Tony, so is there any question you want to ask me? So I'm gonna wrap up what I have talked to you. So the first thing is you are on medication called warfarin, which has blood thinning effect and which can reduce which can prevent formation of blood clots on your heart valves and inside your body. But before the surgery, to reduce the risks of bleeding during and after the surgery, you have to stop warfarin, and we will replace it with heparin. Will replace it with heparin 3 days before the procedure. You will admit to the hospital 1 day before the procedure and get the surgery done. After that, we will switch to we will give you both heparin and warfarin adjusting your iron level. And finally, once we have made sure that bleeding is controlled, you're gonna resume your warfarin as you usually do. Okay, Mr. Tony. Yeah, we'll be here, always here to take care of you and support you. If you have any questions, you can feel free to call me. I will leave my phone number with the nurse.
You still have 1 minute and 20
Okay,
seconds.
okay.
So this warfarin can have minor side effects like bleed, oozing, and bruises around the injections. So, but it is common, but not too critical. So don't worry about it. And another thing is it can lead to liver derangement, heparin-induced thrombocytopenia, and last but not least, bleeding inside. But however, bleeding is not common. But unfortunately, if you have if you have side effects like that, you can seek medical attention at GP or your emergency department, whatever is nearest to you. Okay, Mr. Tony.
Okay, doctor, my question is, but after operation, okay, I would like to continue heparin injection, but I don't want to taking warfarin pill. So I would like to continue the heparin injection. Should I continue it?
We don't recommend injecting heparin throughout a long period because warfarin is way easier and it is just swallowing the tablets, and it is safer and easier to assess the level. This is why we do recommend patients to taking warfarin for the long run.
Good, thank you.
Sorry.
Okay.
Thanks.
Okay.
So can you first give feedback to Dr. Cynthia? It was good. Seemed like a good conversation. Anything?
Yes, she present very well, madam.
Yes. Anything that she needs to improve on? No, it was good. Yes, Dr. Gangan. Yes, please.
Good evening. It was a good station. The doctor did very well to rule out most of the things. She said she covered most of it.
Yes.
I don't know if I heard her well, or maybe it's from my own side. I thought that the patient was supposed to be in the hospital when the patient stops taking the warfarin, and then the patient will be in the hospital when he's being given the heparin 5 days prior to surgery. And then this patient is legally blind.
Yes.
Well, I don't know, maybe showing empathy to the visual impairment that the patient has.
Yes.
That's another point. Thank you, ma'am.
Yes. Thank you. Yes, good. You recalled.
Yeah, thank you.
Yeah, because here patient is legally blind, so you have to ask if the lights are disturbing him, and you can maybe dim the lights, and you can ask this even when the patient would have sunglasses on, even in the room, so you can show little consideration by asking that. But patient would not be in, because patient would be living alone. Patient is legally blind, so the options that she offered were reasonable. That if he cannot come, or if he cannot take the medication himself, that then she can arrange a social worker or nurse or maybe a GP to make a home visit and make sure, or at the end can even be admitted. Yes. So like this. So that was all right. Yeah. Yeah, right. Good. Thank you. And here is the question. Right. So if you have read and understood, considering that history taking station, kindly begin.
Yes. I am Dr. Khawar Rahman, a surgical doctor, and I want to talk about your problem. What is your name and age?
My name is Alexander. I'm 54 years old.
Where do you live? Which city area?
So
You have
I'm
to
living
ask.
in the center of the capital.
Okay, okay. What problem do you have?
Doctor, I noticed problem when I'm eating something. So I noticed this problem around 8 months before.
Uh, do you have difficulty in swallowing?
Yeah. When I'm eating something, I cannot eat.
It's constant or intermittent?
It is intermittent.
You have
Is
to
it
use
related
layman.
to?
Yes, layman voice.
Okay. Is it related to solid or liquid food?
So first I developed this against solid, and then gradually it's progressed to liquid.
Associated with pain?
No,
No. Which can you eat? You told me that you have difficulty with food. Do you take it or saliva?
yes, I can take saliva.
Okay. Have any weight loss?
Yes, I lost my weight from the last.
Okay. Do you have any swelling in your neck?
No,
No. Do you have cough? Do you have any problem?
no,
And when you eat something, will it come back to your mouth?
no,
Okay. And do you have any neurology, any brain problem, any chest problem?
no.
Okay. And do you have any pain in anywhere else in the abdomen? Anything else? Heartburn?
No, doctor, there is no any pain. No, doctor.
Okay. And do you smoke?
Yes, I'm smoking, and I'm taking around 1 per day.
And do you alcohol? Do you take alcohol? Any other drugs?
Yes, taking alcohol.
Okay. Do you have any other family history, social history, family problems? Any this problem in the family?
Yes,
Hello.
my elder sister had the same. Yes, my elder sister had the same problem, and unfortunately, she died around 2 years before.
Okay. Do you have any past medical or surgical problems? Previous medical or surgical illness?
Uh, so, what do you mean by medical problem?
Do you have any diabetes? Any gastritis? Is that type of problem?
No, no,
Stomach problem?
no,
No. No surgery?
No,
Okay.
no.
Okay. Do you have when you eat food, your neck will swell or there is gurgling? Is it present? No.
No, I haven't noticed any gurgling when I'm eating something.
Okay. Yes, I have completed the history, madam.
Yes, but not quite. Did you ask about
Okay.
the idea, concern, and expectation? You still have 50 seconds, so please ask.
What is your idea about this problem? What do you think?
So I think it's the critical condition. As I told you, my elder sister also died from the same problem. So I think it could be due to any type of cancer.
Okay. And what is your concern about this disease? What?
Worry about this disease because I'm the only person in my family which I took risk of. That's why I'm really worried about this.
In this condition, what do you want about your treatment and management? What
Okay.
are your expectations?
Now, can you please present your history?
This 54-year-old male has difficulty in swallowing for several months. He has weight loss. He is also a smoker and one pack cigarette per day. There is no other associated problem, and he has no neurological problem.
So what are your differential diagnosis for this patient?
My differential diagnosis are mechanical and functional. Mechanical may be esophageal cancer, pharyngeal cancer, cricoid web, and gastroesophageal reflux disease, peptic structure, and the functional are maybe some stroke, globus, pharyngitis, and diffuse
How would
esophageal
you
spasm.
confirm your diagnosis? What investigations would you ask for?
First of all, I will assess my observation, then I will do the cardiorespiratory examination and abdominal examination, and I will do the ECG to rule out the myocardial infarction. Then I will do the blood CT reactive, and then I will do the X-ray chest, and if there is no perforation, then I will go to CT scan chest and abdomen.
What are the treatment options that you can offer to this patient?
It depends on the stage of the disease. If it is limited to the esophagus, then I will discuss this case in the MDT. And if it is resectable, I will offer the patient about transhiatal esophagectomy, in which I will go from abdomen and cervical approach, or transthoracic approach, that is abdominal thoracic. If it is unresectable, then oncologist will be involved department, and I will go for chemoradiotherapy and neoadjuvant therapies and stenting.
Okay,
Palliative
thank
treatment.
you. Right.
Yes,
Yes, this was first time you presented history taking, and history taking is a skill. It's an art. We'll work on it. First of all, you have to remember that, okay, once you introduce yourself, then you have to take a little consent that I'm exam candidate and I'm here to ask, I'm supposed to ask you questions if it's all right with you. First, your name and age. You don't have to ask where the patient is living or where, because time is only 6 minutes. And in 6 minutes, you have to take the whole history. And if you ask the patient extra questions, this will cost you your time. So no asking where patient lives or from where he or she comes from. Then you'll take a little consent for taking the history. And then you'll begin, like you asked, what is your problem, or how can I help you today, or what has brought you today? So this way. And then you ask about the presenting complaint. Almost everything you have covered. I think about halitosis is the one which was left. about the
Yes,
question.
madam.
Yeah.
Madam?
The remaining, yes, please.
Demography is not important in history taking demography.
No.
Okay.
And there are certain questions that I would want you to go back, listen on the YouTube channel. Other dysphagia history taking, at least 3. Then you'll realize that you have to address the patient in a layman language. You can't say, do you have any other neurological symptoms? The patient would not understand what neurological symptoms. You have to say, do you feel weakness anywhere on your body, on any side? So you have to be specific and you have to be like easy. And then you can't say, do you have any medical conditions? Like you have to tell, are you suffering from diabetes, hypertension, hypercholesterolemia, or like you have to give example 3, 4, and you have to mention. And then you can't say if you have had any surgical condition, then you can ask if you have ever been operated before for any reason, right? Or if you have any family member who's suffering from the same condition. So these are the, yeah. And then a social history you have to take. You asked about the cigarette, you asked about the alcohol, then you have to ask if the person, who are you living with? Do you live alone? Then you can even ask this question. So socio-economic
And
there, yes.
madam, he didn't show sympathy. It's very
Yeah,
important when you're taking history.
yeah. When patient told you that he,
Madam, there's no need to ask the name.
no name. You have to ask the
No
name
name.
and
But
age. I did say you have to ask the name and age, but not the geography, not the demography, not where the patient is living or from where he or she is coming from.
okay.
Yes. And when the patient, you ask the patient that what is the problem, how can I help you, and the patient told you about the condition, then you have to say, I'm really sorry to hear that, because here it's the most common condition which you have to rule out is the esophageal carcinoma, or because the patient did tell you patient has unintentional weight loss as well. So these things, and then layman language you have to use as much as you can. And at the end, you have to ask about the idea, concept, and expectation. So what do you expect from us to do for you? After this, there is a little systemic review kind of question that you have to ask as well. But then if you don't get the time, then you can say, if time would have allowed you, then how would you have completed your history? So if in today, like you kind of mentioned or asked everything, so yeah, we'll work on it, Dr. Howard, doesn't matter. Don't get disheartened. History taking is not an easy thing. It's an art, you know. You have to, one has to practice. Like if each topic, if you
Yes, ma'am, it
practice
is need
30
practice.
seconds, if you practice 30 times like each topic, then you'll become perfect. Definitely. Good. Thank you. I started the timer and here is your question. Right, so if you have read and understood, considering its clinical examination station, kindly begin.
Yes. So
You'll enter the room, you'll greet the examiner, you'll wash your hands, and then
yes.
you'll
Okay.
take the consent. Yes.
Take my yes. So as hello, I'm
Yes.
the surgical can could you
Yeah, ma'am is back. I think you can.
Welcome back, ma'am.
Welcome back.
I'm sorry,
Welcome,
I
ma'am.
got disconnected. So